call the first speaker, Dr. Sampaio, to talk has about topics and tips for ultrasound in phlebology.
Thank you. Ladies and gentlemen, dear colleagues, it's an honor for me being invited for Dr. Júlio Ferreira and his team, and Dr. Angelo Scuderi, for being here and for opening this Brazilian session. I will talk a little bit about, in fact, my experience as a phlebologist, as also a sonographer. So we'll talk a little bit about topics and tips for ultrasound in phlebology. So we are here because as surgeons, we want to improve our results. And inaccurate surgery is our main problem still right now, even with the newer technologies, not only for treating, but also for diagnosing. And inaccurate surgery could reach at maybe 27% or more. So there's a lot of sequences regarding inaccurate treatments that starts with diagnosis, ultrasound, and finally the comprehension of the disease. It should be the bigger problem. So in the beginning, the medicine was done with hand, heart, and mind. Then, one immigrant from Czechoslovakia, Dusik, was the first one to use venous ultrasound to get venous ultrasound waves of the brain in the 40s. Then devices became smaller, cheaper, and more reliable, and probably this will be the next step. So where we are nowadays, I'm sorry, Dr. Júlio Ferreira, with his laser saber, and Dr. Angelo Scuderi, his Syrian. Probably I would never be invited again. Okay, but ultrasound is behind the newer technologies, and everything has improved, and doctors must improve it, so results will improve. Patient has a two-dimensional perception of the disease, and we as a doctors must have the three-dimensional perception. This, you can be fully thinking two-dimensionally. This is not Júlio Scuderi, Júlio Ferreira behind the Ferrari. So that's what's happening. When they are just looking at the surface of the problem. Very nice. And we know that there are a lot of interferences between superficial and deeper veins. So to the naked eye, we can only see a small part of the disease. And ultrasound can gain us this kind of deeper perception of the disease. Ultrasound has been told as a disadvantage of being operator dependent. You should take this disadvantage as an advantage, because maybe someone will see in this image at the groin only vessels and everything else looking better, and one can see even an elephant here. So it depends on the sonographer to do a good treatment. What could affect the ultrasound results? It's been proven, or studied at least, that sitting or standing position cause differences. Room temperature, time of the day, compression, decompression, efficiency, leg relaxing during the and of course, your experience. Why to do ultrasound by yourself? You must do it at least one time before surgery, throughout surgery, of course, and after surgery, because of interstitial area. If you study well, you can align the anatomy and better comprehension of the disease. And also, it could help you to choose the better technique that you have available to treat this segment. The interest area, well studied, will help you to decide which veins to treat, which techniques will choose, and also helps you to take care with anatomical variation that can reach up to 25% of the patients. Defining the saphenous vein, this is an expanded image just above the knee, and as you can see, there's a main reflux from the groin to the knee, and there is an aplasia at the knee level, and the varicose veins are in the knee level. So it's very important that you know this before start treating this patient. This is the saphenous compartment, as everything knows, and this is, at this moment, the anterior area. Red The red vein is a reflux vein, and this is the saphenous vein. If you have this situation, you can choose probably many techniques, and the laser radiofrequency streaming or from sclerotherapy, the better that you can do. But if you have an aplasia and you have an accessory vein as a dominant trunk, you can use probably the same techniques if the vein is deeper, distant from the skin. But if you have a saphenous vein, but you have a main dominant trunk, an accessory vein, you probably better use inversion streaming or even mini phlebectomy if these veins are very close to the skin. So you will avoid many consequences. Sometimes you have to combine treatments and use one technique for the saphenous vein and another technique for the accessory vein. Sometimes you have real duplications in the same fascia, saphenous fascia. You can have maybe 2 or 3 saphenous veins, very rare, but I have seen 2 saphenous veins many times. Sometimes it's a kind of mess, a confusion, and it's hard to decide where to start the treatment. This is a good ultrasound done by a good laboratory in my city that shows in the same patient, you will see the next step. In the same patient, a reflux in the saphenous vein as a main dominant trunk. This is the ultrasound done by yourself. When you realize that this patient has a stent aplasia of the saphenous vein and have a dominant trunk very close to the surface. So, with the first exam, probably you will choose by a streaming, endovenous ablation, or foam sclerotherapy. But when you do the ultrasound and you see that this vein is very close to the surface, maybe you should choose stripping for inversion. Maybe. I'm not telling that this patient needs this type of treatment. These are just samples. Before doing ablation, ultrasound helps you obviously to understand better the disease, but especially to see which veins are good for ablation or don't. Ultrasound also can help you before the surgery. This patient is 70 years old, female, with a saphenous vein with reflux at the thigh level, and with an accessory anterior vein that has caused thrombophlebitis in superficial varicose veins. The ultrasound was used to help us to mark the surface and help us to gain time during the surgery. And the another one is the aspect after 1 week of surgery. Ultrasound have also improved the streaming, and I have used it in my clinic maybe from the last 15 years before I started to doing the laser. You can use ultrasound throughout the stripping to select the entry point at the time of the surgery. Helps you to stay in the target trunk and not taking a detour to accessory veins, parallels. Also, to save time during the surgery and to reduce recurrence by residual trunks. This is an image of a Phlebo extractor inside the saphenous vein, very fine, very easy to see. This is a simple case, a case with a patient with popliteal veins. It seems to be a very simple case. And looking deeper with the ultrasound, we can see that this patient has varicose veins at the sciatic nerve, and this is the sciatic nerve here, and there's also an accessory short saphenous veins with reflux, also interfacial and parallel to the short saphenous vein. There is also a perforator vein at the popliteal cleus, and it causes those small varicose veins at the external aspect. So, having a good mapping and understanding very well the disease, you can choose if you want just to treat the superficial veins with the technique that you want. Or if you would like to use the perforator vein to gain access to the inner veins and to treat the varicose veins of the sciatic nerve, maybe from sclerotherapy, and also that interfacial vein. Sample case number 2, it looks similar. This patient has been submitted to a surgery 7 years ago, and there was a recurrency in the posterior aspect of the thigh. Looking closer, and here you can see for spontaneous contrast that there are a high reflux in the gastrocnemius vein, causing an proximal hyperflux and hypertension in the short saphenous vein. But it's not reverse overflow. It's a progressive, it's a proximal overflow. So it leads in this region, the overflow in the right direction, but causing a leaking to superficial veins because this was the last target surgery situs. And once the disease has residual, okay, now having a good mapping and understanding much better the disease, you can choose which techniques you would like to use. For example, ligation of the gastrocnemius vein, or mini phlebectomy, or sclerotherapy, and maybe have better long-term results. I'm not saying that you should do this or should choose these techniques, but now if you have these techniques available, then probably you'll do it very better. Also, ultrasound to preventing misdiagnosis. For example, this case, this is an hematoma intrafacial after stripping. Is very easy to do, but using new technologies, you used to do ultrasound very often in post-operatively. But during the stripping, no one of us asked the ultrasound after a week. So if you don't know, you could misdiagnose it as a thrombophlebitis in a residual saphenous trunk, but in fact it is an interfacial hematoma, and the simple it will be a herpes. You use ultrasound to check post and laser results. Also, fibrosis, absence of flow. Here you can see a neuroma of the sciatic nerve just around the popliteal vein, and this is a bed ablation I have done. So, since we are talking about ultrasound and images, I will show some very short videos, don't worry. Here is the sample of echo-guided stripping, not newer. Everybody has done newer technologies, but this is an unflabbed structure inside the veins, and you can use ultrasound for that. And this patient has wall flaws caused by phospholipidic disease, and you can use the ultrasound to help you to guide the phlebous structure to gain access to the upper parts of the saphenous trunk, so you stay in the trunk. Also, you can check the catheter before starting the laser, and you can compress sometimes the skin, and you can see better. Inject saline solution with small bubbles helps you also to see if you are with the catheter in the right place. Flush injection of saline solution, and this will help you to stay in the place that you really want. There is the tip of the catheter, and if the whole set is well positioned, you can do your measures, and you can be sure that you are in the right place before starting the fire laser. Here, during the tumescent anesthesia, I have observed that in the cases that I accidentally perforate the saphenous vein during the tumescent anesthesia, I have more bruising. And then, finally, firing a laser just to check if you are in the right place before going down. A few minutes later, you can see that the ablation was well done, and you have just a small stump, and there is no more flux in the saphenous veins. So this is very helpful because you don't need to expect for 1 week or nothing. After the treatment, it's very often to see bubbles, steam bubbles in the deep veins, and this is very normal. And also checking after in the laser ablation here, 1 week after the laser, the same case, and you can see that it's all set, well done, and compressing to see that you are okay with your treatment. So, thank you.
Inside the operating room. Congratulations for the beautiful presentation. It's not here.